And then, yeah, they're very good. They're really good about it.
Good morning.
If anything, I always say, feel like there's just so just to make so good this whole this year.
So that part I didn't ever think about
It does have an impact on We're gonna also see you.
Yeah. Sorry,
When I take tests and I pass them, and I cry when I say, gosh, I the tears of joy. So I'm sure they're like
Cars.
Yes, it was.
School bus.
Your little one did say that that's crazy.
He does do really crazy. He's gonna be 13 in 5 months. It used to be like during pregnancy, not so much now. So
That's a whole package. She said,
Yeah.
Good morning. I apologize for being a few minutes late here this morning, but let's call the meeting to order. And as soon as I lay my hands on the agenda, I'm sure if I've got one in
I
my
don't think
bag.
there's one in here.
Okay. The first thing on the agenda is to approve the minutes from our last meeting.
I motion we approve the minutes. I'll second.
Any discussion? Okay, the minutes from our last meeting have been approved. Does anyone have additional items they would like to add to the agenda? Okay, there being none, we will approve the agenda. Could we have the financial report, please?
I do. We received our approval for our cost reports for the year. And so I did billing for July, August, September, and October. And we billed $73,441, which is just about 35% of our allowable funds for the year. And when you do the math, we should be at around 33. So we're pretty much on target because things do slow up during the winter months. People aren't using our services quite as frequently, so.
Very good. Okay, old business. So under old business, we have had, trying to see who's here, a request from Mary Stanley to review her situation once again. Does everyone remember Mary Stanley and her situation? Okay. So Matt has very graciously helped me put together some recommendations. We've also, I discussed the situation with Maggie, our attorney, as well. And really, Mary wrote quite a letter to me, which I am not going to read to you. If anyone would like to see it, I do have a copy of it here. But basically, she wants to get a building permit and be able to proceed with her son's home building in without doing anything with the current septic system, is my interpretation of her goal. So I think the bottom line are a few things. One, Mary is doing this petitioning when it's her son's land and her son's building permit. So she really legally isn't the authorized person to make these moves. Two, our county code or the laws or whatever say that we can't hook up new construction to existing septic systems without at least a certified validation that they're up to code and watertight. Please jump in, anyone who knows what I'm saying, if I'm saying this wrong. So, and you two both saw the information that I emailed to you before the meeting with those recommendations from Matt and so forth. So I think it's in the best interest of the board and going forward in the recommendations that I've received that we uphold our previous decision. But we need to have some discussion on that because I agreed after Justin, who's on the county supervisors, talked to her and said that we would rediscuss this. And we agreed that we would rediscuss it. And so I've put in, Matt got us further information. Matt,
Do you want me to jump in?
you can sure jump in if you have.
So
Yeah, you can say it better than I can.
after Mary Stanley's request to come back and reconsider again and possibly go with a time of transfer inspector to, since the state trains them on inspecting the septic systems and they do up a report every time a property is sold. I reached out to the Iowa DNR and provided the letter that Dan Olson sent back to us in regards to that. He did not want a time of transfer person to get involved in the inspection of this system, and he just warned myself that, he's like, any further manipulation of the code than what we've gone so far as allowing the licensed engineer to inspect it, he said that would set a really terrible precedence. And since the board's original decision and recommendation of allowing a licensed engineer to be able to inspect septic systems so that they can be reutilized again like that, we have had one other person, Horizon Equipment in Avoca, had 2 tanks sitting out behind their facility, and they did just have an engineer go up and certify those tanks because they want to now adjust that system and add on lateral fields. So that, I believe that process is a workable one. It helps take the liability off of us as the county. And once that engineer puts their stamp on it and tells us that it's good, then we can utilize that to stick in with the file and say that the system on that day was certified to be up to code, so.
So as the chair of the board, I think we've given this a lot of consideration. You have both seen the letters that Matt sent me. I forwarded those to the board and also from the state. So I would like to issue the recommendation that we remain with our same motion and recommendation that we gave before, that she can either, and this needs to come from her son, I understand from Maggie, either choose to have the engineer inspect the current system and then go forward with coming back for their building permit, or they can just get a new septic system and a building permit per the code of Pottawattamie County. So is there any other discussion with this or concerns or questions? So I think we should have a motion to seal
I
this
motion
off.
that we stay with our recommendation, our motion that we already made. Then she needs to get the approval.
Okay, all in favor?
Aye.
Any opposed? Okay, so there we go. The workforce development plan. Joe, we looked at this at our last meeting, I think briefly, but it's also, is it in our packets here? Joe?
No, because it went out, I handed it out last week.
Yeah. It's from the last meeting.
Yes.
Yeah. So that was the workforce development plan policy. Joe, do you have anything to,
I don't really have anything to add, other than this is part of the FAB accreditation to move forward with public health to be accredited. We have, the agency, public health, needs to have a workforce development policy. Kind of substantiates, what and we used a lot of the language that's in there is in the National FAB accreditation, that we, we look at when we are a very aging workforce, as much as I hate to say that. We are. And we do need a policy so that we're not discriminatory and we're not, so this is where it kind of stems from. It was something that we, as a 3-county, Mills and Harrison County, said we would work on this year. And we wanted your approval of it before it actually gets sent. And I apologize, I didn't bring extra ones today.
Do you have, Amy, have you reviewed it? I reviewed it from our last meeting. So we ran out of time at our last meeting to actually act on this, and so it is here. Is there, I'm going to give you two a couple minutes to look at that a little bit closer.
You need a motion to approve this.
Right, and we're discussing the changes that you want to have put with it.
Is that what this is about?
That's the next piece of agenda, so this is a separate policy for us.
I'll make a motion.
Okay. So,
I'll make a motion that they approve this.
I second.
okay, it has been moved and seconded that we accept the workforce development plan policy as presented. Any further discussion? All in favor, please say aye.
Aye.
Any opposed? Okay, so the motion has carried that we accept the workforce development plan as presented. Our next policy that we need to discuss and approve is this conflict of interest policy. And this is something that we need to have in our Board of Health policies as an annual, on an annual basis with annual review. So the conflict of interest policy, does everyone have a copy of that out there? They need to see it.
I don't think I ever signed them.
So this policy recognizes that the board is aware of any conflict of interest that they may have performing their duties as a member of the Board of Health, and requests that we make full disclosure and discussion of any conflict of interest.
I'll make a motion to approve this.
Okay, so it's been moved to approve. Is there
I
a
second.
second? Any discussion? Dawn?
So it's required that the board signs off on this conflict of interest annually? Maybe it says it in there.
It does, I don't have the signatory page, I will mail that out to each.
But probably until you get the full board again, I mean, that, I shouldn't do it before then, but then every year annually.
Right, so this is an annual form that we
You do approve.
will.
I've signed about 3 of them.
So we have a motion and a second to approve this as an annual conflict of interest, I am having trouble speaking today,
It's hard to say.
policy. And All in favor, please say aye.
Aye.
Anyone opposed? All right, so we will proceed with getting signatures for that for this year and then doing it annually moving forward. So we'll address this again at our January meeting for 2018. All right, so that takes care of our old business for today. Under new business, the first item on the agenda is the election of officers for 2018. And in our board bylaws, the last meeting of each year, we elect new officers for the next year. And those officers go into effect at the end of this meeting and moving forward according to the bylaws. So, that being said,
You accept this?
would anyone else like to do it?
No.
No, you're doing such a good job.
I will do it. I believe I can do it for one more year, at which
Okay, I
time my,
nominate you then.
my term will be.
I second.
Okay, so, do you want to say proposed slate of officers stays the same, or do you want to elect each person? Well, we need a vice president who is, Amy, are you a vice president?
Yeah.
Yes. So I am the current chairperson, Amy is the current vice chair. Joe from the BNA does our secretarial,
Or Diane.
or Diana does, sorry, Diana.
No
pressure. I think you should be the vice.
No.
All right, well, let's go this way. The motion has been made and seconded that I remain as the chairperson for the next year. Is there any discussion? All right, all in favor, please say aye.
Aye.
Anyone opposed? Okay, so that motion has carried. We need a motion for the vice chair, please.
And Amy's currently.
And Amy is currently the
Would Amy
vice.
take it? Yeah.
I suppose.
I nominate Amy then.
Okay, so have you made a motion?
I'll make a motion that Amy continue as vice president.
So the motion has been made that Amy continue as the vice chair for the next year. Is there a second? I'll second that motion. No, I can't second. All in favor?
Aye.
Aye.
So that has been carried as well.
I nominate Diana takes minutes as secretary.
And we'll continue to have Diana take minutes as secretary. So in essence, we have carried our slate of leadership from 2017 into 2018. Is there any further discussion? All right. So I have communicated through Matt and Justin to the Board of Supervisors that we have two, well, Rita, did you, obviously we've elected you. Rita, okay, the next item of business on the agenda is the Board of Health position, and I guess I'm moving forward to the membership of the Board of Health. So we have two open seats that I am aware of on the Board of Health. Rita, did you fill out your paperwork to stay on the board?
And you get that, didn't you, Matt?
I did get that, yep.
Okay, so Rita has done that. We need a physician for the Board of Health, elected or appointed by the Board of Supervisors. Has there been any discussion with the Board of Supervisors?
I do already have an application.
Okay.
It
So,
hasn't gone through the approval process yet.
okay. So, I guess.
When will that happen?
Soon.
Well, at the end of December, we will be without a physician officially, and I think we need one to keep conducting business.
any type of medical.
When Justin originally asked me to submit out to everybody and to get the applications and process going, I believe he planned on, but before December 15th, having a meeting to get those appointments made for all the boards and commissions.
Okay. So I'm glad to hear you have an application. Do you have any other discussion or?
I can fill you in a little bit on the person. His name is Dr. Michael Guzman. He is fresh out of residency. He will be taking over the CHI clinic in Oakland. He's a very exciting person to talk to, very well educated. He has a lot of good connections over at UNMC and Creighton programs, and it'll be exciting to have him.
What's his last name?
Guzman?
Guzman, Guzman.
Well, thank you for that.
You're welcome.
Very good. All right, I don't think there's any other business or anything we have to say regarding that, so. The next thing on our agenda then is our presentation by Linda McQuinn, and she is the disease specialist with the Iowa Department of Public Health. Thank you for coming, Linda.
When I was talking to Joe at the last meeting, I was asking if any of the STDs has been talked about, and we're seeing increases. So I think it's important you have just a little overview of what's been going on. Okay. Why? How do you forward the slides?
You click the mouse.
Just a mouse? There it
There
is.
we go.
Thank you. Okay. This is the map right now. There are supposed to be 7 of us in the state. If you notice also that the yellow spots are local health departments that actually have people like me just for their county. On the west side, there's just 2 of us for the state. The sad thing is we just found out we lost one of our people. They have to move. So my territory, the pink territory, will get a lot larger. I'll probably be back to 23 counties going east of I-35 temporarily, probably for about 6 months. Okay, what we do in our department, which I'm in the HIV, STD, hepatitis bureau, is we're out making sure that not only the labs, but the doctors are reporting reportable cases to us. We do something called partner services on some of the diseases, the high priority diseases, which I will discuss in detail later. We encourage screening and have a screening program, as Rachel is part of our screening program in this county. The next closest ones are Omaha, Sioux City, and Polk County, basically. And we do help supplement the Planned Parenthood clinic when someone has no insurance, doesn't want to, they want to test but doesn't want to turn it in on their insurance. We help out there. Part of my job is to make sure people are treated properly when there is adequate treatment. If they can't get treatment, to make sure that they do get treatment. Sometimes the doctors can't locate them back to get them in the office. I've even picked up the person and brought them to the doctor's office. We also have a condom program. We offer free programs to anyone, tattoo parlors, doctor's offices. I got a lot of doctor's offices now that are supplying condoms to people. Anywhere where someone will put them out where people can grab them. WIC programs, the grandmothers will grab them for the grandkids. We see a lot of different places we can put them. Food banks, because if they can't afford food, they can't afford condoms. So we're doing that. Now, partner services, this is what I do. This is what I've been trained to do. Part of it is education. The person maybe hasn't been talked to about the disease. Doctors don't always have all the time. We educate them on the disease in the hope that they will lower their risk once they understand the diseases. So the reportable diseases are HIV, syphilis, gonorrhea, and chlamydia. We have, on partner services, HIV is a high priority, so is syphilis. Gonorrhea is our next high priority. And we try to reach everyone and talk to them about partner services. One way to lower their risk is to make sure all their partners are taken care of. A lot of times we find the partner doesn't want to go in because they're afraid of the exam or what might happen, or they don't have money. So we offer like Rachel's services. This is a free clinic. Your partner can get in there and get treated the same day they're tested. It's a voluntary program and it's a highly confidential program. I cannot divulge the person's name. Like they say, I don't know how to tell my partner. I will do that for them. If they're in another state, it's sent to a person like myself in that other state, and they do it. At that point, they always ask, well, how do you know this? Who was it? We say it's someone who cared. Someone who cared, who wants to make sure you're okay. So we're giving you information so you can make health choices for yourself. Again, it's voluntary whether they go in or not. Some don't, some do. We also try to encourage HIV testing at this point. If there is one sexually transmitted disease, there could be others, so we are pushing that right now. Again, the confidentiality, that speaks for itself. Okay, chlamydia. This is last year's statistics, just under 13,000. Right now, they are looking at the statistics for this year, and they said there's definitely an increase on this. It's going to be over 13,000, they're saying. Most of these cases run in under 25 years of age. So that's where we're trying to talk to the private doctors, educate them. We're running out of public funds. We're running out of family planning clinics. You need to be our champions now. You need to get out there and start testing more. They come in for an earache, talk to them about STDs. I see a lot of missed opportunities where later I'm going back on their person. They say, well, I was just at my doctor. He didn't mention anything about it. So nationally, 1.5 million. Gonorrhea. Last year's numbers was 2,600. Roughly, this was in the last 3 years, there has been a total of 75% increase. They've already looked at our numbers for gonorrhea, and they said most likely it will be 100% increase from 4 years ago. This has been a real issue with us because of gonorrhea is one of our superbugs. It's one of the bugs that is building a resistance to all the meds we have. We are running out of medications. So we are really double checking treatments with the doctors on the gonorrhea. It takes a dual therapy to take care of gonorrhea now. Nationally, there's just under 500,000 cases. Again, you can see with the top line is chlamydia, the bottom line is gonorrhea. Both have been going up. And then we have just a gonorrhea chart. And see that it's yes, it's under 3,000 or it's around 3,000 cases, but this could, if we get a resistant strain, this could be very detrimental. I worked in Omaha when the penicillinase gonorrhea occurred, and that is an awful situation. So we're really pushing to try and lower these numbers on gonorrhea. Syphilis, about 90% of the cases are men who have sex with men or bisexual. And I say bisexual because we've had a little bit of increase in congenital syphilis. This is fairly distributed across the age groups. I've had as old as a 72-year-old primary syphilis case. And it can go down into the teens. So there is a wide open area on syphilis for age groups. If someone comes in, we tell them if someone comes in for a gonorrhea chlamydia check, you should be thinking syphilis and HIV. And this is infectious syphilis. This would be the early stages. Within the first 6 months, they're most infectious to other people. You can see we're seeing increases in that. We had a slight decrease, but I'm seeing more this year again too. This is infectious syphilis compared to total syphilis. We sometimes find people who may have had it for over a year or 4 or 5 years and never knew it. So we're treating them. It just takes more treatments. And there is a shortage of bicillin, which is the drug of choice. When a doctor can't get it, we have it at our public health clinics, and we will treat. Congenital syphilis, this is the scariest and high-risk situation. In Iowa recently, since 2014, we have had 4 cases, and that's 4 too many. And there have been deaths involved with the babies. So that's why I'm saying the bisexual thing is crossing over again to the women. And we're encouraging the private doctors to start testing not only prenatal bloods, which it's done then, but talking to their clients, seeing if they've changed partners in any way, and testing towards the last trimester to try and catch it early. HIV testing. This has been a recommendation for general practice for probably 7 years now. Anyone who comes into your office between the ages of 13 and 64 should be at least offered an HIV test. They should be talked to about their sexual life. If there is no sexual activity, let's say they're 13 or 14, no sexual activity, talking to them about lowering their risks in the future and protection. The issue is we're trying to find the people before they get sick. It's cheaper to do it that way. And the sad part is I've had probably about 6 HIVs in the last 4 weeks. I've had to take care of. Of those 6, 4 were rural. We're seeing it more in rural Iowa. At least 25% of new HIV cases are happening rurally across the whole state. I saw missed opportunities. I saw definite missed opportunities. Some I was pretty angry about, but we go back with those clinics and try and talk to them about, are you doing this testing? What's holding you up? Is it discussing it? You're afraid to talk about it? Put up a sign. Put up a sign in each exam room that says, ask me about an HIV testing, something to start that conversation. Most people tell me, especially younger ones, is that if they were offered a test, they probably would have taken it. They're afraid to ask. And they know they're high risk sometimes. People with certain risk factors should get it more often than once a year. If you are a man who has sex with another man, not necessarily gay, not bisexual, some men do not consider themselves that, but do have sex with other men. If you've had sex anal or vaginally with a positive partner, if you've had more than one sex partner since the last test, if you've injected drugs or shared needles, or any of the works, the cotton, the spoons, the bowls, the snorting mechanisms, those all can be issues. Exchange sex for drugs or money. And I gotta say, I had a 68-year-old gonorrhea case rurally that paid for his sex in high-risk areas. So I could not convince that doctor to offer that man an HIV test. So there's a lot of work to be done yet here. Diagnosed with or sought treatment for any other sexually transmitted disease, there should be an HIV test with it. Been diagnosed or treated for hepatitis or tuberculosis. As we know with tuberculosis, that's one of the opportunistic diseases for HIV. And with syphilis, it's the same way. If there's syphilis, they should have an HIV test. Out of all the new syphilis cases, about half of them will turn HIV positive in 3 months. Had sex with someone who you could answer yes to any of the above questions. You should be tested. Another thing that Joe and I talked about is, she said, well, what can we do? How can we stop these issues? One way is the condom distribution program. The other way is, we now know how to stop HIV. If we can convince our medical community and the public, we can stop this. There are two issues with HIV. There's PrEP and PEP. PEP is post-exposure. If you're a medical provider, you're accidentally stuck with a needle, you can be offered, along with all the testing, you can be offered the HIV drug for anywhere from 30 to 90 days to say, let's just not take the chance of you turning HIV positive. The other one is PrEP, and I gave you a new card. We just got these cards on PrEP. We're going to be passing these out. If you're in any of those high-risk groups we just talked about, and your test is negative, that physician can write a prescription for the HIV drug, and they can just take one pill daily and protect themselves from picking up HIV. The case the other day I talked to, I had tested in other places and said they did discuss PrEP with me. I should have done it. Because they're positive now. So it's convincing not only private providers to start talking it more, but the public to say, yeah, I am really high risk. This is going on across the nation now. We're pushing this issue. We have programs. If someone has no insurance, if they don't want to turn this in on their insurance because they have to go through testing every 3 months also, we have a program now I can refer them into, and it's a phone call. And it can be, if they want, it can be set up wherever they're at. And we were thinking rurally. A lot of people don't want to go to their rural doctors and do this. So the program is working real well. We're getting people on PrEP right now. And the rest of this program is something I would do with the private providers. It's about an hour presentation I normally do. I'm not going to go through the screening guidelines. I can get you a copy of the PowerPoint if you want, you're interested. But basically, we're pushing for testing with the private providers. I have been working with Methodist and talking to all their physicians. And I'm trying to get into other places and do that also in my county areas. So if there's any questions, I'd be happy to answer them.
So you cover, pink and purple was a little unclear to my eyes on your screen here.
Right now I have
Oh,
16 counties,
Right
yeah.
now you have our quadrant of
Yes.
southwest Iowa, but you're gonna go all the way up to the northern
No,
border?
actually, I'm gonna go east, south and east. And it's only temporary until we can get a new person hired on. They're already working on it and trained. Technically, I've had 23 counties until this year, and that person just took over some of my counties. I get like Lucas, Warren, those counties. And they haven't done the official map yet. We just got told this last week, but I'm pretty sure I'm gonna be getting my old territory back.
And it sounds like one of your best strategies is to educate the physician offices, all the
Right.
local physician offices to offer.
So start talking
To
the talk.
start with assessment and screening.
Yes.
And then,
Yes, and there is online through CDC, you can get a free app onto your phone. It's the STD 2015 treatment guidelines. In there is a sexual history thing that talks to the physician about what questions do you ask, how to ask them, and not do it where you're, upsetting the client that you have or the patient you have. So we are trying to work with them because in my area over the last few years, I've lost 2 family planning clinics. There are no services. And I've been referring over the Missouri border to family planning clinics. They have lessened on that side. There are very few services on that southern border now. So people have to travel a long distance to get it's Rachel we were referring to, or Planned Parenthood. That's what we have left to refer people. And a lot of the doctors are not A man may go in and say, I know I'm exposed to gonorrhea. The doctor will do a urine test for it, not asking him if he's had sex with other men, because I've had some men who say, I never use my penis, I only do oral and rectal. So if you're not checking the right areas, you're gonna miss cases. And they're thinking they're fine when they go out in the world. I catch some of those because they end up being on a list of partners to other cases. And I talk to them and they tell me this and I go, okay, let me go over your story again. You have to understand that that test only tested one area. I can offer a clinic that can do these other tests free. And some of them will take up on that offer and we find cases. So it is getting very scary out there, and it's mainly educating the physicians. I am talking to them now, I need them out there. I don't public health money is dwindling, we all know that, in all the programs. I need those physicians to start owning up and saying, I am gonna talk, and not look at someone and say, well, they look like they could be okay and not okay. I have a lot of married couples that bring a third party in, an unknown third party. And both are having sex with that individual they bring in. So if you don't ask whether they're married or not, if you don't ask, you're not gonna know. And you can't really care for them properly at that point. So it's just a matter of education right now. And then at the same time, educating the public and talking to them about their risks. And if they're that risky, maybe they should think about PrEP also. We can stop HIV right now. But I have both sides still questioning, well, I don't really think I need it. We have some people, maybe they've gone through 2 syphilis infections in a year, and it's really hard to talk into them, like, next time could be HIV. It's really hard to talk them into that. Some of them at that point do see the light, some don't.
What do you see your needs being to the Board of Health? So obviously your strategy to get education out there is comprehensive for one person or your team. And
Yeah.
then
But
public
talking to the,
education.
well, talking to the boards of
resources.
health, you're in the community.
Mhm.
And some of you are medical, and you're talking to other medical people. You can refer, you have someone who says, oh, I didn't know those things, you can refer them to me. I will help them any way I can. A lot of times I get into the doctor's offices because I helped them with the case, and they're seeing, oh, what that does. And that's how I got into Methodist, because they couldn't find someone to finish the syphilis treatment. And I worked with them several days, drove the person to them, got them treated, and at the same time they accepted condoms into the office, and we started talking screening, other screenings. You're not screening enough. I should be seeing more cases, So it's a process of word of mouth a lot of times. That's why the Board of Health. I don't know, I've been working this area in Council Bluffs in southwestern Iowa for over 35 years. I started in Omaha 3 years before that, working the STD program. So I know the area. We have lost a lot of free or low-cost services. I do need the private sector's help now. And Board of Health, talk amongst other medical people, other community programs, youth programs. We'll go in and talk to youth. Rachel goes into the jails and talks to the high-risk people. We are just trying to get the word out and at least get them thinking. Maybe I should come in for a test. Maybe I should talk to my doctor about this.
Well, you have a wider population of people than one would traditionally think about too.
Oh, for STDs, yes,
Yeah.
yes.
For sure. Is there any other questions?
Any questions? Yes.
Is there any, brochures or posters or anything? I'm the WIC coordinator, so.
I do have some, yes.
Especially, have things changed, you may need another HIV test towards the end of your pregnancy. that kind of thing? or
I
is
don't
there
have
any-
a poster like
for
that,
But,
yeah.
okay, well, and anything, but that's good to know that that still happens.
Yeah, I do have some other posters that are on HIV.
Mhm.
A wide variety, it can be two men together. And we kind of talked about this at our meeting this week, is that there are, men who have sex with men or gay couples or lesbian couples that are actually raising families now. And that WIC would be an ideal place to promote that they are family also. You know, and it discusses HIV very briefly on that poster, so yeah, I can get you some things and.
Totally. You can send it with me Tuesday.
Yeah, yeah.
I'll take it.
Thank you. So, and you still have condoms, right?
We just got another box.
Okay, good, good. Anyone else? I thank you for your time.
All right, thank you very
Thanks,
much for
Linda.
presenting. Okay, Maria, we had a couple, did we just have one septic variance this?
Yeah, but we need to have an official action on it,
Right,
and you have to have
Get her
three
back.
members to have an official action.
oh, Amy, she left her proxy vote to approve that, can we do that, or no? Let's see if you can grab her, Jim.
She has a meeting at 8:30.
Yeah. All right, we had, just stand right there, real quick. Go, Maria.
All right, we had a septic variance request. It was forwarded to everyone by email on October 10th for the address of 19750 Beverly Manor, Council Bluffs, Iowa, and it was to install the laterals within 10 feet of the northwest and east property lines. It was approved by email about October 10th by members Hoffman, Pearson, and Zijek, with no conditions.
Is there a motion to approve this variance?
I approve.
All in favor, say aye.
Aye.
Okay, thank you.
Thank you, Amy.
Wait. Do you adjourn?
Well, yes, we'll adjourn, and then I'll say a couple of other comments. Is there a motion to adjourn?
I motion to adjourn.
Is there a second?
Second.
All in favor?
Aye.
Okay, thank you, Amy. Post adjournment, we did receive reports from all of our other people today because of Amy's short ability to be here at this meeting. And I appreciate those reports. We have reviewed them, and I don't know that we have any other questions. We can't conduct further business. The other thing I wanted to say is Monday night, in follow-up of our strategic planning that we did on September 30th, our team as part of our action plan from the strategic planning, the Board of Supervisors, the City Council, the Mayor, the City Board of Health, and our Board of Health are scheduled to meet Monday night at the Council Bluffs Public Library in Conference Room A at 6 o'clock. That is an open meeting. We will be discussing our strategic plan and our structure proposals going forward. So if there are any people that are interested in that or wishing to attend, that meeting is posted. I just wanted to make people aware of it as a follow-up from our strategic planning that we did in September. All right, appreciate people being
May I
here.
ask one question?
Yes, Rita.
On the immunization audit, Tanya,
Yes.
what do you mean by invalid? Does that mean they're just incomplete, or?
They were, they didn't have the required vaccinations for either the licensed daycare. I think those were all daycares. So they were missing vaccines or they were out of schedule.
So you reviewed 578 of them, but it was 107.
Yes, that needed corrected,
Yeah.
corrected, yes.
Okay, I thought that's what it was, but I thought, well, invalid.